Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient with gradually worsening bilateral hearing loss, imbalance, a broad-based gait, and brisk reflexes. The ear examination is unrevealing, but the neurological examination points towards cerebellar and pyramidal involvement. One important diagnosis to think about is superficial siderosis. Superficial siderosis means chronic or recurrent bleeding into the subarachnoid space. Red blood cells break down in the cerebrospinal fluid, releasing heme and iron. Over time, this iron is deposited as hemosiderin along the pile surfaces of the brain, cranial nerves, and spinal cord. The result is progressive neurotoxicity. The classic triad is sensorineural hearing loss, cerebellar ataxia, and sometimes myelopathy. The key clue is slow progression, especially when bilateral sensorineural hearing loss is combined with gait ataxia and upper motor neuron signs. To understand the pathophysiology, think of a slow leak of blood into the CSF. The source may be a spinal dural defect, previous trauma or surgery, a vascular malformation, or a tumor. Red cells enter the CSF, break down, and expose the nervous system to iron. Initially, glial cells respond by producing ferritin to bind iron. But with chronic exposure, this protective mechanism becomes overwhelmed. Hemosiderin then coats the CNS surfaces, particularly areas bathed by CSF. Why does cranial nerve 8 suffer so characteristically? Because the vestibulocochlear nerve has a long glial segment exposed to CSF. Iron toxicity damages it, leading to progressive, usually bilateral sensorineural hearing loss. Why does the cerebellum become involved? The cerebellar vermis and folia are exposed to circulating CSF. Iron deposition injures Purkinje cells, so patients develop truncal and gait ataxia. And why can myelopathy occur? Hemosiderin coats the spinal cord surface, affecting long tracts, especially corticospinal pathways. Clinically, this gives spasticity, hyperreflexia, and pyramidal weakness. Clinically, the most typical presentation is slowly progressive bilateral sensorineural hearing loss with imbalance or cerebellar ataxia. Pyramidal signs may appear as the spinal cord becomes involved. Other features can include anosmia, cognitive impairment, bladder dysfunction, radiculopathy, and headache, especially when there is an associated CSF leak or intracranial hypotension. Do not confuse this with isolated vestibular disease. Vestibular disorders may cause dizziness and imbalance, but they do not usually explain progressive bilateral sensorineural deafness, plus cerebellar signs, plus corticospinal tract signs. The combination is the clue. The investigation of choice is MRI of the brain and whole spine with iron-sensitive sequences. Gradient echo or susceptibility-weighted imaging shows a dark hypointense rim coating the cerebellum, brainstem, cranial nerves, and spinal cord. This dark rim represents hemosiderin. Contrast MRI can also be useful. Pachymeningeal enhancement may suggest a dural tear or CSF leak. Once superficial siderosis is recognized, the next step is to look for the bleeding source. That usually means detailed spinal imaging, and if a dural defect is suspected, CT myelography or digital subtraction myelography may be needed. Management is based on one principle: find and stop the bleed. Repair a dural defect if present. Treat a vascular malformation or tumor if that is the cause. The earlier the source is controlled, the better the chance of preventing further neurological decline. Differentials, an iron chelator, may reduce CNS iron burden, but established neurological recovery is often limited once axonal injury has occurred. If differential is used, monitoring is essential because of the risk of a granulocytosis and neutropenia. Supportive care is also important. Patients may need audiology input, hearing aids, or cochlear implant assessment. Vestibular rehabilitation, gait aids, spasticity treatment, bladder management, and fall prevention can all make a major difference. MRCP trap: the diagnosis is not made by routine MRI alone if the correct sequences are not used. The exam clue is iron-sensitive MRI showing a hypointense rim along CNS surfaces. If you remember one thing, remember this. Superficial siderosis is chronic subarachnoid bleeding causing hemosiderin deposition, classically presenting with progressive bilateral sensorineural hearing loss, cerebellar ataxia, and pyramidal signs. Quick recall: a patient has progressive bilateral sensorineural hearing loss, gait ataxia, brisk reflexes, and MRI shows a hypointense rim around the cerebellum and brainstem on susceptibility-weighted imaging. What is the diagnosis? And what is the underlying mechanism? The answer is superficial siderosis, caused by chronic or recurrent subarachnoid bleeding, leading to hemosiderin deposition and iron-mediated neurotoxicity. A patient with superficial siderosis has pachymeningeal enhancement and suspected spinal CSF leak. What is the key management priority, and why might hearing recovery still be limited? The answer is to find and repair the bleeding source, such as a dural defect, because stopping further bleeding prevents progression. Hearing recovery may be limited because established cranial nerve and axonal injury may be irreversible. Do subscribe to the channel for further videos.